Well, thanks for having me here. And as Cindy said, we had the Kids Get Scleroderma 2 event the last 2 days over at Children's Hospital, which was absolutely a blast. Kids from all over the country. And Start kicked it off on Friday night with a Halloween costume dinner party, and then families all day yesterday. So it's great to kind of continue the Scleroderma weekend with you guys here today. The point of this talk is not to go completely in depth on scleroderma. That is, obviously all of the manifestations could take their own weekend. So this is really designed more to just be a brief overview about the disease and approaches to treatment, and then you'll hear more specifics on other aspects of living with this illness throughout the day. So today, the things kind of just as an outline to talk about is what do we even mean by this concept of an autoimmune disease? Who gets it? Why do they get it? A brief overview of the types of scleroderma, and a brief overview of the approach to treating scleroderma, both the skin manifestations and other elements. So the cartoon up there says it all sounds Greek to me. It's because it actually is. So the word scleroderma comes from the Greek meaning hard skin. And that's one thing that, despite what type of scleroderma someone has, is one thing that kind of unites them all, is the hardening of the skin. In terms of this concept of autoimmune disease that you'll hear quite a lot of it about, and I'll have a couple of slides on that, but essentially what happens is your kind of army, so to speak, that's there to protect you against the outside world and protect you from all the viruses and bugs and bacteria, it turns on you and it starts putting that attack on your own body. The two basic types of scleroderma that we'll chat about briefly, localized and systemic. The systemic form in adults is the more common, and that's what's referred to as systemic sclerosis. And even though the two types share some common features, namely the hardening of the skin, they're actually two completely different illnesses, and one does not morph into the other. And I think that's an important thing to keep in mind, especially if there is anyone in the audience with localized scleroderma, just to bear in mind again, localized scleroderma does not become systemic scleroderma. So what do I even mean by autoimmune disease? So even to answer that question, we have to take a little bit of a step back and have a little bit of immunology 101. So for all of us, the way our bodies stay healthy is through your immune system, and that's all of the cells running through your blood, your T cells, your B cells. And their job is, the way they keep you healthy is they recognize, a foreign invader, a virus, a bacteria, and they say that's not supposed to be here. And they mark it and they label it so that other parts of your immune system can get rid of it. And part of the getting rid of it process involves inflammation and creating a really inhospitable environment for these foreign invaders. And the kind of primary driving factor are these proteins that are called antibodies. And you can kind of think of them as your soldiers against invasion. And the graphic that's up there with the little Y-shaped doohickeys, the reason they're shaped like that in a lot of cartoon depictions is that just their molecular structure kind of looks like a Y. So whenever you hear about antibodies, you'll see this kind of Y-shaped thing. In autoimmune disease, that immune system is really kind of misdirected, and the way I phrase it to patients a lot is I say, you are an overachiever. In addition to doing what your immune system is supposed to do with fighting off the bad stuff, it's kind of like your immune system has a really phenomenal gas pedal and a really crummy brake pedal, and it doesn't know when to call it quits. And so in addition to just fighting off the bad stuff, that attack can get turned in on yourself. In the process of doing that, you can make these things that we call autoantibodies. So as the name implies, the auto is self, and antibodies refers to these guys. So instead of just having antibodies against foreign things like bacteria and germs, you start building antibodies that actually recognize your own body. And so what is an antibody? So this kind of cartoon gets at, so plasma cells, this is a type of B cell. I am a pediatrician, by the way, disclaimer. So everything has smiley faces and whatnot. So your plasma cells are spewing out and making these Y-shaped proteins, these antibodies, and normally they attach on these foreign bacteria, these, the guys who aren't supposed to be there, and that kind of marks them so that these eater cells that are also part of your immune system can come along and gobble them up and get rid of them. So an autoantibody, instead of making the attack against something foreign, can actually recognize your own body. And sometimes there are some illnesses where that directly is as straightforward as it sounds like. You actually do eat up, so to speak, kind of parts of your body, but honestly that's actually pretty rare that it happens that directly. Usually it's a much more indirect process where those autoantibodies are binding with other parts of your immune system. They're kind of creating these big lumpy complexes that can get stuck in places and trigger inflammatory responses. And other times, we see the antibodies when we look in your blood, but we don't actually know what direct role they play. They're really more of kind of a surrogate sign that just says, hey, something's up with your immune system, something's gone amiss. These antibodies are here. We don't know exactly what role they play, except that they're a sign that something's going on that shouldn't be. And we care about them even if we don't know exactly what role they play, because the hope is that the more we study things like that, the more it may be able to give us insight and say, hey, you have this specific antibody, that means that you're at a higher risk for this complication. So if I start seeing certain signs, I'm going to pay a little bit more closer attention. Whereas if you don't have any of them, then maybe you're at a lower risk, and maybe we don't have to be quite so aggressive in treatment. So I think that even though we may not know exactly the role they play, we're still, from a research standpoint, interested in following them, since they may be able to help direct kind of our approach to treatment. In terms of scleroderma, kind of the two hallmark things that are going on are fibrosis and blood vessel problems. So the fibrosis, which is kind of another way of saying scarring, involves kind of tissue inflammation that ultimately turns into hardening. And this little cartoon guy here, this is kind of, so it's supposed to be your skin. So essentially what that would be is if you took a little piece of your skin and you started like looking at it kind of in cross section, like head on. So the top part here is closest to the surface, the bottom part here is closer to your bone, and the deeper you get. And so just under the skin surface is this layer of collagen, which is kind of what we call a connective tissue, and that's kind of just supposed to be this bouncy, springy layer that gives your skin kind of some of its texture. And if there's inflammation in here, a couple of things can happen. Initially, it can kind of, if there's swelling, expand and look kind of swollen, but ultimately, if it scars, then it can kind of bound down, and that reflects the process we see often in scleroderma, where you start with this sort of swelling expansion and then ultimately kind of bind down, and it can get harder to move and sort of lose that flexibility. The other thing that can happen is a similar process can happen in your blood vessels, where the walls of the blood vessels, if they get too hardened or swollen, they can kind of push in, and so the diameter, the tunnel that your blood has to go through gets smaller, and that can cause problems as well if not as much blood is getting where it needs to go. In terms of who gets scleroderma, so the localized form, and I think I have a slide in a little bit, but localized essentially is when you just have a patch of skin changing, either a line or a patch on your body, but it's not throughout your whole body and it's not your internal organs. The prevalence of that, which is essentially the word that we use to say at this point in time how many people out there have this condition, about 50 per 100,000. It's predominantly a childhood onset illness, so in pediatric rheumatology we see a whole lot of this. Adult onset is rare, but it does happen, and it does happen to women more often than boys. For the systemic form of sclerosis, systemic sclerosis, it's about half that in terms of the numbers, and average age of onset for systemic disease is in adulthood. We do see it in children. About 3% of cases start in childhood. Interestingly, in really young kids, the male to female ratio is about equal, but then once you get into school age and beyond, it tends to happen more often to girls and then women in adulthood. But I think the biggest question for anyone with a chronic illness is the natural one of why. Why is this happening? Why me? Why not my friend? Where did I go left when everyone else went right? What did I eat differently? I mean, you can, after a new diagnosis, microanalyze your life until you drive yourself absolutely batty trying to think, why is this going on? The truth is, it's not one simple answer. It's probably a combination of a lot of things that come together as the perfect storm. that we know there is, for some people, genetic risk, that there likely are environmental factors. There's probably hormonal factors, kind of underscoring why females more than males is not an equal ratio. But however all of those things come together, at the end what they're resulting in is that your immune system is not functioning the way it's supposed to. Those inflammatory signals that trigger inflammation are not functioning the way that they were designed to, and ultimately that leads to abnormalities in your collagen and other connective tissues. I think the most important bottom line, and what I always like to stress to my families, is it's not your fault. It is not something that you did that you were not supposed to do. It's not something that you didn't do that you should have done. It stinks and it's unfair and it's not your fault. So this is the slide I was kind of referring to that just really super briefly breaks down the types of scleroderma. So the two big columns here, localized and systemic, each have different, just in medicine as doctors, we like to be geeks and give a million different labels to things just to make it more complicated. But what under localized scleroderma, morphia is referring to cases where there's just kind of like a singular plaque, a singular area of skin. And I have some pictures in a little bit. The linear form is when it's more of a line along the body. And then there can be other distributions as well. Those are just the two most common. For systemic scleroderma, limited and diffuse refer to the kind of the skin body surface area that's affected. And that little cartoon there kind of depicts the difference in terms of the white versus the purple area. But again, it's kind of how we differentiate the different manifestations that you may have with the systemic form. In pediatrics especially, we see a lot of what we call overlap syndromes, where you may have not just scleroderma, but also features of lupus or something called dermatomyositis, where your muscles are inflamed. It can definitely happen in adults too, but I think we see that a bit more often in pediatrics. But bottom line, systemic affects more than just your skin. Localized affects just your skin, and localized does not become systemic. For the localized form, just in case there is anyone here, with it, essentially it's, again, so this picture of the person with the leg here, this is the linear form. So there's binding of the skin and tightening of the skin and a stretching across joint lines there, which is why that person's foot is kind of inturned. Even though it's predominantly just skin, you can have involvement of other parts of the body, especially if it's in the face. So this little girl here has involvement of her face, but most likely my suspicion is there's dental issues underlying here, because it can involve the deeper tissues down to muscle and bone. When we have kids who have lesions on their head, they can have central nervous system involvement. When it's on your arms and legs, if things are binding down and entrapping nerves, it's not uncommon to have malfunction of the kind of the sensory nerves and the motor nerves, something that we call neuropathy. And these are just kind of some pictures so this is a girl with linear scleroderma of the head. This is one where it's kind of affected the arm and the leg, and then the morphia or the circumscribed lesions are more these kind of circular areas. For adults who get localized scleroderma, this is the most common form that they get. In terms of the treatment, the biggest kind of treatment goal with the localized scleroderma is to really minimize the impact of the disease on life and improve function. And it's a combination approach. So part of that is supportive care, emollients, keeping your skin kind of protected from the elements. Paraffin soaks for hands can be super helpful. We do a lot of phototherapy, which has been shown to help some of these lesions. A big piece of it is the physical and occupational therapy from a mechanical standpoint and stretching. For kids and adults who have lesions that go over the joints and actually limit how the joints are able to move, often surgical interventions are needed at some point once we get the disease under control. But a big piece of it is controlling the inflammation, and that what underscores there and is similar in systemic disease is that it's easier for us to control inflammation than to control fibrosis and scarring. And so we like to kind of act aggressively and act early to get that inflammatory process under control. Using a lot of the medications we use in the localized form are similar to what's used in systemic, although there are some differences. And then, so for now, we're going to merge and talk about the systemic form, systemic sclerosis. And so this is kind of a multi-system autoimmune disease, again, characterized by a vasculopathy and by inflammation that turns into fibrosis. By multi-system, what we mean is it can affect pretty much anything from head to toe. It doesn't mean it is destined to affect everything from head to toe, but we definitely keep our eye on everything to monitor for complications. And these are just some example photographs. My guess is most people in this room are familiar with the phenomenon of Raynaud's syndrome, where you get kind of the spasm of the blood vessels that are feeding the hands and the feet. This is someone who that has happened to such a degree that she started to have really bad ulceration at the tip of her finger. In terms of how we as doctors diagnose and classify this, there's this list of all, a number of different potential manifestations, and essentially you have to add up and get a certain number of points. Some are worth more than others. But from a kind of medical standpoint, that's what we're looking at when we're kind of classifying these illnesses to come up with diagnoses. And even though there can be specific manifestations, I think, not to underscore the fact that just being inflamed and having a chronic illness can make you feel really lousy, and sometimes just that is even more of a detriment to quality of life than anything else. That fatigue, fevers, malaise is the medical word we use for just not feeling well. And so even though we may focus on a lot of the specifics, I don't want to lose sight of the bigger picture of the forest. In terms of skin manifestations, the skin tightening really truly is the hallmark of this disease. And the Raynaud's, that kind of whitening and blue color change of the finger for many, many patients precedes the rest of the onset of disease by, it can be years that you have just the Raynaud's before other symptoms show up. With the Raynaud's, because it is essentially, it's that vasculopathy, that kind of tightening of the blood vessels that's limiting the flow of blood to the fingertips and the toe tips and other parts of the body, there really is a risk for having skin breakdown from the lack of oxygenated blood, something that we call finger ulcerations. And so we'll kind of talk about skincare a bit, but keeping hands warm is super important, and keeping the rest of you warm too. We talked about first things will get inflamed before they scar down. So this is a picture of someone's hand who's kind of in that more edematous, swollen phase before things really start kind of fibrosing down. And kind of characteristic features on the face, kind of just tightening and making it hard for kids to open their mouth and for adults to open their mouth. I may by default keep referring to kids. I do mean patients in general. Heart and lung manifestations are a big thing that we like to keep our eye out for. Obviously, those are really important parts of the body, so we need to be on the lookout. And it can affect things in a few different ways. The first is just simply having tight skin and tight chest muscles can make it hard to expand your lungs and hard to take deep breaths. Interstitial lung disease is kind of the name that we give to this inflammatory scarring inside the lungs. And if the inside of your lungs are scarred, as you can imagine, the same way if your chest wall is tight, it's hard to expand. If the inside of your lungs are hardened and scarred down, it's also hard for all those little air sacs inside your lungs to really expand and be able to process and take in oxygen, which can then lead to symptoms of being short of breath and having a cough. Pulmonary hypertension refers kind of to the impact that tightening can have as the blood is flowing through the heart. So the normal path that your blood takes is it goes from your heart to your lungs and then kind of goes back to your heart. But if the combination of having a really kind of scarred down fibrotic environment inside your lungs combined with that happening inside the blood vessels going through your lungs, all of that is making the diameter of those blood vessels really small. And it limits how much blood is able to travel through your lungs and pick up oxygen. So it then, by default, ends up limiting how much oxygenated blood makes its way back to your heart and to the rest of your body. And ultimately, the way we all function is by having the newly oxygenated blood run through our body. And so when you're limiting that, that can also lead to symptoms of shortness of breath and fatigue. Other symptoms, and I know we're going to chat about some of these more in depth by other talks later today, so I won't go into huge detail, but from a GI standpoint, the analogy I keep in my mind is just think of a hard rubber tube. Normally we want our esophagus and our intestines to be able to contract, have motility, absorb things, but if it's just a hard rubber tube, it's kind of, things are going to slosh up, which is what we call reflux. It's going to have impaired motility of things going all the way through. And then there's going to be nutritional impact. If the lining isn't as pliable as it's supposed to be, you're going to have a harder time absorbing the nutrients that you need to from your food. From a renal standpoint, we have an entire talk about renal manifestations this afternoon, so stay tuned. That's the trailer. Neuropathy, we talked a little bit about before. Again, like if you're having kind of binding down and fibrotic, scarring changes in the skin and the connective tissues, that can impact the nerves that travel through those tissues and can cause symptoms of tingling or poor sensory perception. I think the psychosocial impact, we could spend, again, entire talks, entire days on that. Living with a chronic illness that's changing multiple aspects of your life. Musculoskeletal, in terms of contractures is the medical word when something's kind of held in a position and you can't totally expand and you lose the range of motion of your joints. In terms of treatment approaches, I think that the overall goal of all of it is improving quality of life, limiting progression of the disease, minimizing the negative impact that this has on your life. And again, kind of approaching it from lots of different angles. There's general strategies of support for your body. With the Raynaud's, we talked about staying warm. One thing that's important to remember is a lot of the temperature sensors in your body actually are centrally located. They're there to protect your vital organs. And so yes, it's really important to wear good gloves and good warm mittens, but keeping the core of your body warm is also super important. And general support for the soul, having meetings like this, getting to meet other people going through similar struggles is absolutely huge. From a functional standpoint, physical and occupational therapy to maintain range of motion and, kind of keep going. And then from a medication standpoint, again, to control inflammation, that's a huge part of it as well. So to chat a little about skincare in particular, the other thing to keep in mind is the skin. It's the one thing we can see on the outside. It's harder to look from the outside and see your heart and your lungs. So the skin we use kind of as a window and a clue as to what could be happening underneath. Keeping warm, again, these hand warmers are this time of year sold all over the place. I have a lot of patients who just buy the bulk, like Sam's Club style packs and just have them everywhere. This is my visual reminder about keeping your core warm. From a medication standpoint, other ways to improve blood flow to your hands are with medications that we call vasodilators that basically work by helping to open up those blood vessels to allow more blood flow to go through. In terms of, kind of keeping moisturized, I think it's kind of twofold. Part of it is for comfort because tightening and inflamed skin can be super itchy. The other piece of it is that skin that is super dry and inflamed is also more likely to be injured, and so keeping things moisturized also helps to protect against the elements. In general, creams and lotions that are have a high oil and high fat content tend to work better. Even ointments actually are ideal. They just tend to be a little bit more greasy. But applying right after your shower is an ideal time of day ideal time to do that. A lot of patients will kind of do these hot paraffin soaks, and then even kind of after you've moisturized your hands, wrap them and even, stick them in Ziploc bags, while you're sitting there watching television, just to kind of let that moisturization soak in. Antihistamines, things like Benadryl, as long as they don't interact with other medications that you're on, can be helpful for itching, Zyrtec, those types of things. From a reflux standpoint, because a lot of people with scleroderma do have reflux, kind of back to that hard rubber hose analogy, some things that can be helpful from that standpoint is a little bit of one of those wedge pillows that keep the head of the bed elevated. Having frequent small meals instead of less frequent big meals can be super helpful because it helps just that little bit of food kind of stay where it's supposed to. Trying not to eat late kind of gets mostly at the fact that eating and then falling asleep, even if you have your wedge pillow, I mean, most people aren't really controlling how high their bed is when you're in the dead of sleep. And so, kind of keeping the bigger meals for the middle of the day is good. Avoiding really tight garments around the waist can be helpful for a lot of people who have reflux. Antacids don't necessarily keep you from having reflux, they just make it so that what sloshes up is less acidic, so it hurts more, it hurts less and it's less damaging. And then there are some people whose reflux is actually so bad that the risk is that not only does it slosh back up the esophagus, but it can drip over into your lungs. And so some people actually need to thicken the liquids that they drink so that it decreases the risk of that happening. From a medication standpoint, I'm not going to get into all the nitty and gritty from the standpoint of time, but just to say there are a number of different medications out there. There are some that are taken by mouth, there are some that are subcutaneous injections, there are some that are infusions. There are some that have been kind of more gold standard, others that are coming down the pipeline, and from a research standpoint, I think the two that we're getting excited about from that standpoint is one called tocilizumab, sorry, the font didn't really translate over, the tocilizumab, the trade name being Actemra, and then abatacept or Orencia are some of the newer ones that we're using, and the others listed have been the ones that have been used more historically. I think one thing that is very different, and I don't know if anybody here today is, because since we had the juvenile program yesterday, we invited them to come. So if anybody heard the medication talks yesterday, just to underscore medications between kids and adults, there are very different implications, and our approaches they overlap in many ways, but they're also very different in other ways. Part of that is that kids metabolize drugs differently. The other thing is that some complications seen frequently in adults, such as this concept of renal crisis that you'll hear later about today. In adults, high doses of steroids, there's some discussion about their association with renal sequelae, and so in the adult world, steroids are not used nearly as often in kids. Kids in general don't get renal crisis, and we use a ton of high-dose steroids in our treatment of systemic sclerosis in pediatrics. So there definitely are differences out there, which also is important if you are kind of perusing the internet and consulting Dr. Google, just to keep in mind that Dr. Google is not always your best friend. And then from a pulmonary hypertension standpoint, similar to how in Raynaud's you can use medications to open up those blood vessels, you can also use similar ones to open up the blood vessels in your lungs as well. Bone marrow transplant, I'm not going to go into, but just so you've kind of heard the concept today, essentially what's going on there is it is a way to reboot your immune system, with the underlying thought being your immune system has gone awry, it's malbehaving, it never kind of learned that lesson of self versus not self, so it's a way to reboot that and start afresh. One thing that we do in our management of patients is kind of keep in mind that treatment is not just a matter of treating the manifestations that you see, it's a matter of keeping your eye out for potential manifestations that you can't see from the outside and preventing problems before they arise. And so the ways that we do that is typically with any new diagnosis, we're getting a baseline CAT scan or CT scan. That's really looking at the architecture of the lungs, looking for any of those fibrotic or scarring changes. Pulmonary function tests, which is what this girl is doing in this picture, is where you breathe in and out of a tube, and it's helping to measure how well your lungs are able to do that, what the volume of your lungs is, how air and oxygen diffuse from the outside into the inside of your lungs. An echo is an ultrasound of your heart, and that's a way to really look at the architecture of your heart and see, hey, are the blood vessels this right size, or is the blood flowing through your heart in the right direction? An upper GI, and this acronym here means small bowel follow-through, is a way to measure the motility of your gut and be sure that that's functioning the way it's supposed to. Essentially, they have you drink this liquid, they lie to you, they tell you it tastes like a vanilla milkshake, it does not. It's kind of this really nasty chalky stuff, and then they watch with a camera as it kind of goes through, and they seize the motility the way that it's supposed to. I think the other thing to kind of keep in mind outside of all of the meds is managing a chronic illness. It really can be a full-time job. You've got lives outside of health. You've got stuff going on, and now all of a sudden you have all these different subspecialty appointments, and you're supposed to take this medicine and that medicine. And so for every person, just kind of finding a way to be organized that works for you is helpful. So in the handouts that you have, I just listed here some potential apps that a lot of people have found helpful. There's ones that are medication reminders. There's ones that kind of pop up with reminders about day-to-day tasks, obviously calendars. The other thing I always like to tell people, do you guys all know that on your phone there's a way to store emergency information so that if anything ever happens, people can access that without you having to unlock your phone? So for those of you guys who, and I have this for the Droid too, but if you happen to, since I'm on this slide, have an Apple version, pull out your smartphone, and this is the interactive part. When it's on its locked screen, this little icon down here that says emergency in the lower left corner, that's not just to call 911. So if you press emergency, and I promise if you press it, you're not calling 911, you get this screen that now it pops up and it says medical ID. And if anybody clicks that, they get this screen up here where you can type in medications you're on, your diagnosis, your doctor's name, your doctor's phone number. Medical professionals, EMS are all trained in all of this so that if anything ever happens to you, they can access all of your medical information that you want them to be able to access, even if your phone is off and locked. And the way to also manage the information you put in there is this little, the white health app that has the heart in it. It's not just steps and activity, it actually has a medical information part. And Droid has the similar thing. It's called ICE, or in case of emergency. And so both of the major phone carriers have a way for you to store medical information. I think that's an important thing to keep in mind. And last but not least, just wanted to touch super briefly on research, and not in great detail, but just to say this is what we need, because this is how we better find ways to minimize side effects and toxicities from medication. This is how we find ways to improve quality of life, to prevent complications. And the kind of two main ways that we do that are with what we call registries, which is something where they're not actually making an intervention or just following patients over long periods of time to see how things progress, how people respond to different medications. Often in those registries, not only do we follow clinical manifestations, but we also we may take blood samples or other biopsy specimens and kind of compare them across groups. And then drug trials, where we're actually directly comparing the outcomes using specific medications. One of the difficulties with all of this, though, it sounds really great, but when you're studying rare diseases, it's a lot harder. These diseases are rare. Rheumatologists are rare. This map here, basically by color, represents the number of, in this case, pediatric rheumatologists, but essentially some of these white states here are areas where there's not even a single pediatric rheumatologist. So they're rheumatologists, whether it's pediatric or adult, we are not common. And funding for research is rare, so we need to come up with ways to better be able to actually get data to drive this. So in the pediatric world, what we do is there's this network called the Childhood Arthritis and Rheumatology Research Alliance, or CARRA, and it was a way for all pediatric rheumatology centers across North America to kind of come together to have large databases, because we said one institution by itself is not enough. We need to really have data coming from lots of different places, and it's a way to enroll larger numbers of patients. And by enrolling lots of different patients and collecting their samples and collecting their outcomes, we're able to we came up with what we call a consensus treatment plan, which essentially means if you land at any pediatric rheumatology center across North America, instead of it being a flip of a coin of how that particular doctor is, which meds they're going to use, how they're going to approach treatment, we all came together and said, as a group, expert opinion, this is how we think things should be managed. And what this graphic represents is, in the very beginning, it started with a survey where we said, how do you approach? In this case, it was for localized scleroderma. And pretty much everyone said we use either a combination of steroids and methotrexate. But within the world of steroids and within methotrexate, each of these little slivers represents how different physicians said that they dosed it. Was it given subcutaneous? Was it given orally? Was it given IV? What dosing? What timing? And after the process of kind of all coming together, we were able, with steroids, to land on 3 different options, and on methotrexate to land on 1 option on how we give it. And so now, wherever you are across the country, there's a very limited number of ways that we approach it, and it really helps us better look for outcomes and compare different medication approaches. So just to end, kind of some take-home points. Autoimmune disease, you'll hear underlies scleroderma, and really what that's referring to is a dysregulation of your immune system. Lots of different causes that research is ongoing to figure out, but bottom line, it's not your fault. Other big point, localized and systemic sclerosis have some common features, such as fibrosis and inflammation, but a lot of differences, and one does not become the other. Treatment is a combination of both supportive as well as medications to control inflammation, and research is super important and super needed. So that, I think I may have gone over a little bit, but thank you guys.